Welcome to The Explainer. Today, we're going to take a really deep dive into tuberculosis. This is an ancient pathogen that, believe it or not, still presents huge challenges to modern medicine. We're going to trace its entire story, from a microscopic invader that literally hides inside our own cells, all the way to a global public health issue. And we'll explore the fascinating, complex strategies we've developed to fight back. So, here's our game plan. We'll kick things off with the pathogen itself. Then, we'll get into the weeds of diagnosis, the assault of treatment, and the strategy of prevention. After that, we'll look at what happens when things go wrong with complications. And then, we'll put it all to the test. Let's get started.
Okay, first things first. To really understand TB, you have to understand the adversary. We need to look at the unique biology of Mycobacterium tuberculosis and the brilliant, frankly, mechanisms it uses to set up shop inside a human. So, meet Mycobacterium tuberculosis. Now, a couple of key things here. It's strictly aerobic, which is just a fancy way of saying it loves oxygen. That's why it has a preference for the very top of our lungs, where oxygen is plentiful. But its real superpower, the thing that makes it so clinically important, is its ability to go dormant. It can enter this latent state, hiding out inside our immune cells and just wait, sometimes for decades. This ability to play hide-and-seek creates two totally different situations. On one hand, you have latent TB. Think of this as the bacteria being cornered, walled off by your immune system inside a structure called a granuloma. The person feels fine, they're not sick, and they can't spread it. On the other hand, you have active TB. This is the prison break. For whatever reason, containment has failed, the bacteria are multiplying, causing damage, and now the person is sick and can transmit the disease to others. Now, what's fascinating is that for most healthy people, that prison holds. Only about 5 to 10% of people with latent TB will ever develop the active disease. But that risk isn't static. It's all about the strength of the guards, your immune system. Anything that weakens host immunity, like HIV, or even medical treatments like TNF-alpha inhibitors that specifically target the immune pathways, keeping those bacteria locked up, dramatically raises the risk of that latent infection waking up and reactivating.
Okay, so we know what TB is and what it does. The next big question is, how do we find it? How do we prove it's there? Well, this isn't a simple process. It's more like a diagnostic hunt.
So the hunt begins by getting the right sample. Then comes step 2, microscopy. This gives us our first big clue. Using special stains, we can see these acid-fast bacilli under the microscope, which is a rapid way to gauge if someone might be infectious. But, and this is a huge but, it's not the final answer. For that, you need step 3, a molecular test like PCR, which is usually done right alongside growing the bacteria in culture, which is still the gold standard for figuring out which drugs will work.
And let me be really clear why this is so critical. The microscope can tell you that a mycobacterium is there, but it can't tell you which one. It can't distinguish TB from its cousins, the non-tuberculous mycobacteria, or NTMs. And this is not a small detail. NTMs cause a similar-looking disease, but require completely different drugs and have totally different public health implications. So that molecular test is the absolute cornerstone of a modern TB diagnosis.
And you know, amidst all this complex microbiology, you gotta have a little lab humor. It's practically a requirement.
Right. Diagnosis confirmed. Target acquired. The goal now shifts from finding the enemy to completely eradicating it. And this isn't a quick skirmish. It's a long, strategic assault using multiple drugs at once to prevent the bacteria from developing resistance.
And this table really shows the genius of the strategy. Think of it like a 4-drug special ops team. You've got isoniazid and rifampicin, your main workhorses that kill the rapidly dividing bacteria. Then you have pyrazinamide, the specialist who targets the semi-dormant bacteria hiding out in those acidic conditions inside our cells. And finally, you have ethambutol, who's basically on guard duty, preventing any resistant mutants from popping up. It's this combined, multi-pronged attack that makes the 6-month treatment so effective.
But it's so much more than just taking pills. First, the duration. 6 months is a long time, so adherence is a huge challenge. Then you have the risks. Isoniazid can cause nerve damage, which is why we give pyridoxine with it. All the drugs can affect the liver. And rifampicin, it's a beast when it comes to drug interactions. It messes with tons of other medications.
So this requires constant monitoring. And all of these same principles apply to kids, but their dosages have to be calculated meticulously based on their weight. So we've talked about treating the individual, but that's really only half the story. Because active TB is an airborne disease, every single case is a public health event. We have to zoom out and think about how to protect the entire community. TB is what's called a notifiable disease. That means as soon as a case is confirmed, public health officials are alerted, and a contact investigation kicks into high gear. This has two main goals. First, find anyone else who might have active infectious TB. And second, find all the people who are exposed, test them for latent infection, and treat them to prevent them from getting sick down the road. It's all about breaking that chain of transmission. And inside a hospital, the rules are even stricter, as they should be. Any patient with a suspicious cough gets put into airborne isolation immediately. You get aggressive testing with multiple sputum samples, and a patient stays in isolation until they've been on therapy for a while and have had multiple negative tests to prove they're no longer infectious. It's a very clear, evidence-based protocol to protect everyone else. So, what happens when treatment is delayed or it fails? What are the dangers if TB is left to run rampant? Well, the disease can escape the lungs and travel through the bloodstream, leading to what we call extrapulmonary TB, which is a much more dangerous version of the illness. The damage starts in the lungs, where the bacteria literally eat holes, cavities, into the lung tissue, which can lead to coughing up blood. But if it disseminates, that same destructive process can happen almost anywhere. It can get into your spine, your kidneys, or even the lining of your brain, causing meningitis. And there's a strange paradox in HIV patients. When you start treatment and their immune system gets stronger, it can suddenly recognize the TB and mount a massive, overwhelming inflammatory response called iris. Okay, we have covered a massive amount of ground, from the basic biology to the public health response. Are you ready to put that knowledge to the test? Let's walk through a few scenarios. All right, first question. You're in the lab, you're looking at a patient's sputum smear, and you see acid-fast bacilli. What is your single most critical next move? The answer has to be C. You absolutely must conduct a molecular test. Remember what we said, microscopy is a great clue, but it can't tell the difference between TB and its non-tuberculous cousins, and you have to know which one you're fighting to choose the right treatment. Okay, question number 2. Let's think back to that 4-drug cocktail, the standard treatment. After the first 2 months, the intensive phase, one of those drugs gets dropped for the rest of the treatment. Which one is it? The answer is C, pyrazinamide. It's the specialist brought in for that initial intense phase to help sterilize the environment. Once its job is done, the 2 main workhorses, isoniazid and rifampicin, can carry on and finish the job over the next 4 months. All right, last question for you, and this brings us back to risk. Looking at this list, which one of these patient groups is at a significantly higher risk of their latent, sleeping TB waking up and becoming active disease? And the answer is B, patients undergoing hemodialysis. Why? Because end-stage renal disease causes major problems with the immune system, especially the T cells. And those T cells are the very guards responsible for keeping latent TB locked up. This creates a state of immunosuppression very similar to what we see with HIV, making these patients incredibly vulnerable to reactivation.